So, hello friends, I'm Dr. Puneet Anand. I'm your pediatrics faculty at Nextillo, and I welcome you all in this live lecture series on Nextillo. Today in this lecture series, we will discuss respiratory distress syndrome. It is a very important topic considering the MCQ part and also in the clinical practice on day-to-day in NIC. In this lecture series, we will discuss all the important points relating to respiratory distress syndrome and also some important MCQs later on to revise the topic. So let's start. But before starting this discussion, I will love to thank or like to thank Dr. Sunil for giving us all this platform on this Nextillo app. And also I will inform you all, I like to tell you to join this Nextillo app, to subscribe the Nextillo channel and to download the Nextillo app for helping hands, and you can download the coupon helping hands for 89 rupees for next 3 months. And let's start this lecture session. So first is respiratory distress syndrome. So what is respiratory distress syndrome? It is also known as hyaline membrane disease, and it is most common in premature babies. And what is the most common cause? The common cause is absent or insufficient surfactant due to developmental immaturity of alveolar type 2 cells, or inactivation of the surfactant due to inflammation, most commonly pneumonia. Also, chemical modification, meconium, or the lung injury. So these are the common factors which can cause hyaline membrane disease, or which can cause the absent surfactant or deficiency of the surfactant. Can be due to pneumonia, can be due to meconium, or can be due to lung injury, and most commonly is the prematurity. What are the risk factors that can cause hyaline membrane disease? First and the foremost is prematurity, because there can be absent or insufficient surfactant due to developmental immaturity of the type 2 cells. Then there can be birth asphyxia. There can be acidosis. Acidosis, there is insufficient production of the surfactant, or is also inactivates the surfactant. There can be maternal diabetes, cesarean section, in cold stress, multiple births, history of previous affected infant, or in certain cases has been seen, certain research studies have been seen that males are most commonly affected as compared to the females. So these are the risk factors. It is very important because in MCQs, these risk factors can be asked. Out of all these 4 choices will be given, and it will be asked which is not a risk factor. So it is very important to remember all these: prematurity, asphyxia, acidosis, maternal diabetes, cesarean section, cold stress, multiple births, history of previous affected infant, and a male child. So before going further, we'll discuss something about surfactant also. What is surfactant? It is produced by type 2 alveolar cells in the lungs, and it helps in decreasing surface tension in the alveoli. Mainly, it is composed of dipalmityl phosphatidylcholine, which is known as lecithin. Also, phosphatidylglycerol, apoproteins, surfactant proteins, which are SPA, SPB, SPC, SPD, and the cholesterol. And out of all these apoproteins, surfactant protein B is the most important. It plays a major role. The surfactant production starts around 20 weeks in the fetus, and it peaks at around 35 weeks of gestation. It has been asked in various MCQs, and it is a very important point to remember. When it starts around 20 weeks and peaks at 35 weeks of gestation. In the fetal lung, surfactant can be if it is available, or it can be in the fetal lung, it is available around 20 weeks of gestation, and in amniotic fluid it can be seen around 28 to 32 weeks of gestation. So this was something about surfactant. So what is the etiopathogenesis of surfactant deficiency or the hyaline membrane disease? In prematurity, there is reduced surfactant synthesis, or there is reduced storage and release, which leads to decreased alveolar surfactant, leading to increased surface tension inside the alveoli. So this leads to atelectasis. What is atelectasis? In atelectasis, there is collapse of a part of alveoli or a part of lung, leading to VQ mismatch. What is VQ mismatch? There is uneven perfusion and hypoventilation. This leads to hypoxemia and CO2 retention. Hypoxemia and hypercarbia further leads to acidosis. Acidosis further leads to pulmonary vasoconstriction and pulmonary hypoperfusion. This is very important. This chart is very important because sometimes it can be asked in MCQs. All these pathogenic factors for surfactant deficiency or the hyaline membrane disease. So when there is acidosis, it causes pulmonary vasoconstriction, and pulmonary vasoconstriction further causes pulmonary hypoperfusion. This pulmonary hypoperfusion causes endothelial and epithelial damage inside the alveoli, leading to plasma leak into the alveoli, causing fibrin necrotic cell deposition, which leads to hyaline membrane formation, and so it is also known as hyaline membrane disease. It is very important, which is what is the composition of hyaline membrane? The composition is, it is composed of fibrin and necrotic cells. Now this hyaline membrane further increases the diffusion gradient, further increasing the VQ mismatch, further increasing the hypoxemia and the CO2 retention, and this acidosis further causes decrease surfactant, inactivation of surfactant, and this vicious cycle continues. So as you all can see, the main pathogenic factors are, first of all, there is decreased surfactant. Then because of this, there is atelectasis and VQ mismatch. VQ mismatch further leads to hypoxemia and CO2 retention. CO2 retention will cause acidosis. Acidosis will cause vasoconstriction and hypoperfusion, further causing endothelial and epithelial damage and leading to formation of a hyaline membrane. And this hyaline membrane can cause further increased diffusion gradient, and this vicious cycle will continue. So this was something about the etiopathogenesis of surfactant deficiency or the hyaline membrane disease. This is very important, and this is has to be remembered because it can be asked in MCQs. So we have discussed what was the what are the introduction in we discussed about the epidemiology, we discussed about the surfactant, we discussed about the pathogenesis. Now what are the clinical features of a respiratory distress syndrome? Most commonly it is a preterm baby, around it can be around 28 weeks, 32 weeks, 34 weeks, or almost 35 to 36 weeks, and the symptoms will be present soon after birth or within the first 6 hours of life. When any time a preterm baby presents with respiratory distress soon after birth or within the first 6 hours of birth, the most common diagnosis will be respiratory distress syndrome or a hyaline membrane disease. What will be the signs and symptoms? Symptoms can be tachypnea, there will be retractions, there will be grunting, there will be cyanosis and decreased air entry. So these will be the clinical features of a hyaline membrane disease. So now what we have a scoring for this severity of the respiratory distress syndrome or hyaline membrane disease. It is known as Silverman-Andersen Retraction scoring. It is the preterm babies divided into 5 body parts: upper chest, lower chest, xiphoid retractions, nares dilatation, and expiratory grunting. So these are the 5 things we see in the Silverman-Andersen Retraction scoring. And it is divided into 3 grades: grade 0, grade 1, grade 2. In the grade 0, the upper chest, there will be synchronized retractions. In grade 1, there will be lag on inspiration in the upper chest, and in grade 2, there will be seesaw upper chest retractions. In the lower chest, there will be no recessions in grade 0. Visible with naked air. So this was about the Silverman-Andersen retraction scoring. And what will be the interpretation? Interpretation: score 0 to 3 will be mild respiratory distress. Score 4 to 6, there will be moderate respiratory distress. If the score is more than 6, it is an impending respiratory failure. And if score 10 is there is severe respiratory distress. So this is about Silverman-Andersen retraction scoring. Further, when we do a chest X-ray of these babies with respiratory distress syndrome, chest X-ray is diagnostic. It will be showing reticogranular pattern. It will be showing ground glass opacities, low lung volume, air bronchograms, homogeneous atelectasis of the alveoli. White lung will be seen with black bronchi that don't collapse. There will be air bronchograms and white-out lungs. That is, cardiac and diaphragmatic border will be not visible in the severe disease. So this is a chest X-ray of a severe respiratory distress syndrome. As you can see, these are low lung volumes, and the white-out lung is seen. White-out lung, that is, the cardiac and diaphragmatic border are not visible, and air bronchograms. There will be homogeneous atelectasis of the alveoli with black bronchi that do not collapse. So this is a very typical X-ray of a severe respiratory distress syndrome or a hyaline membrane disease, and the treatment we will be further discussing. But whenever you see a premature baby with low lung volume or white-out lung, most common diagnosis will be a hyaline membrane disease or a respiratory distress syndrome. And the most common cause for death in these babies can be alveolar leaks, most commonly pneumothorax, or a pulmonary hemorrhage or the intraventricular hemorrhage. So these can be the most common causes of death in all these babies. So this was certain something about the clinical features, that the premature baby presents soon after birth or within the first 6 hours of life. There can be tachypnea, there can be retractions or grunting, cyanosis, and decreased air entry, which is scored by Silverman-Andersen Retraction scoring. And if the score is 0 to 6, it is categorized as mild to moderate respiratory distress. If the score is more than 6, it's impending respiratory failure. And when the score is 10, it is a severe respiratory distress. And chest X-ray is diagnostic. There can be reticogranular pattern, ground glass opacities, liver disease. In the death, the most common cause of death can be alveolar air leaks, pulmonary hemorrhage, or the intraventricular hemorrhage. So, what about the management? How these babies should be managed? First of all, as we have discussed, acidosis can further inactivate the surfactant, or they can further decrease the surfactant production. So, first of all, the most important should be temperature maintenance. Hypothermia should be avoided in these babies. In mild to moderate respiratory distress syndrome, CPAP is the modality of the treatment. It helps in recruitment of alveoli. And in the severe cases, ventilation should be done. Most commonly, and the definitive treatment is endotracheal surfactant or the exogenous surfactant. The surfactant is given through trachea, and the treatment, it is a treatment of choice for moderate to severe disease. How the surfactant helps? Surfactant, we give surfactant from outside through the trachea with the help of endotracheal tube. It helps in maintaining a low surface tension. That is, the surface tension which is increased because, or the surface tension which is high because of the absence of surfactant, it is decreased when we administer the surfactant, and the alveoli are patent at low pressures. So this is about the surfactant treatment, and it is due to other complications are hypoxemia, bradycardia, apnea, pneumothorax, pulmonary edema. They can be the potential complications of surfactant therapy. What about the target SpO2? Target SpO2 on all these babies should be 91 to 95%. Avoid giving 100% oxygen to prevent retinopathy of prematurity. It is very important. We should never give oxygen more than 100%, or we should never target SpO2 more than 95%, because the risk of retinopathy of prematurity is very high in these babies. So the target SpO2, this is also important MCQ that is asked. What should be the target SpO2 in treating HMD, hyaline membrane disease? It should be around 91 to 95%. So this was about something about the management. We have to avoid hypothermia. In mild to moderate diseases, CPAP is given. In the severe disease, or there is impending respiratory failure, baby should be ventilated. And the treatment of choice for moderate to severe disease is exogenous or endotracheal surfactant administration, which helps in decreasing the surface tension and keeps alveoli patent at low pressures. And what are the potential complications? There can be hypoxemia, there can be bradycardia, pneumothorax, and pulmonary edema. They are very common complications after surfactant therapy. So we should monitor for these also. And always the target SpO2 should be 91 to 95. So this was about treatment. Now, how do we prevent hyaline membrane disease? The most important thing for prevention of hyaline membrane disease is the administration of antenatal steroids to all the mothers who present with preterm labor or are planned for preterm delivery. And why antenatal steroids are used? They are used because it has been observed that maternal hormones, especially the glucocorticoids, promote surfactant maturation. So that's why antenatal steroids are used, which are based on the observation that maternal hormones, especially the glucocorticoids, promote surfactant maturation. Antenatal steroids not only decrease the respiratory distress syndrome, but also decrease the risk of intraventricular hemorrhage, patent ductus arteriosus, necrotizing enterocolitis, and overall preterm mortality. So these are all the important benefits of antenatal steroids in preterm. And what is the target population? The target population is the pregnant females, which are 24 to 34 weeks gestation pregnant, who present with preterm labor or are planned for delivery. This is very important. What is the target population? Pregnant females who are 24 to 34 weeks of gestation pregnant, with presenting with preterm labor or are planned for delivery. Now we use two steroids for all these antenatal steroids for this preterm prophylaxis of hyaline membrane disease prevention. That is betamethasone and dexamethasone. Earlier, it was said that betamethasone is beneficial as compared to dexa, but now research has proved both of these are equal, and research has not demonstrated superiority of one drug over the other. So both are equal in prevention of hyaline membrane disease. Betamethasone, the dose is 12 mg intramuscular, two doses 24 hours apart, and dexamethasone, the dose is 6 mg IM intramuscular, 4 doses 12 hours apart. So that's very important. You have to remember the dose. It has been asked in MCQs. It has been asked which two drugs are used for prevention, and also what are the potential benefits of this antenatal steroids. So betamethasone and dexamethasone are used. Betamethasone dose is 12 mg intramuscular IM, 2 doses 24 hours apart, and dexamethasone the dose is 6 mg intramuscular, 4 doses 12 hours apart. And only contraindication for this antenatal steroid use is chorioamnionitis. It is the contraindication. So this was all about the hyaline membrane disease. We discussed about the epidemiology. We have discussed about the clinical features, and we have discussed about the X-ray. We discussed about Silverman-Andersen scoring. We also discussed about the treatment, and what about and also about the prevention. That is, we use antenatal steroids, and the betamethasone, dexamethasone are used, and the doses we have also discussed. Now, this was about all this hyaline membrane disease. Any questions we have before we progress to the question and answer session? Okay. So the first question is, which of the following will favor the diagnosis of respiratory distress syndrome in a newborn? Choice A, receipt of antenatal steroids. Choice B, air bronchogram in chest X-ray. Choice C, it manifests after 6 hours. And choice D, it occurs after term gestation. Which of the following will favor a diagnosis of respiratory distress syndrome in newborn? Receipt of antenatal steroids, air bronchogram in chest X-ray, manifests after 6 hours, or occurs after term gestation. So if we discuss all the choices one by one, receipt of antenatal steroids. Obviously, it can be given in not every preterm which has been given steroids will favor the diagnosis of respiratory distress syndrome. One thing is that it manifests air bronchogram in chest X-ray. It can be one possibility. We'll discuss other choices also. The choice C is manifests after 6 hours. We have already discussed most of the cases, and majority of the cases in the respiratory distress syndrome will present soon after birth or within 6 hours of life. So this is not correct. Occurs after term gestation. Obviously, respiratory distress syndrome or hyaline membrane disease is a disease of prematurity. So this is also not correct. So the right answer is that is air bronchogram in chest X-ray. So which of the following favor the diagnosis of RDS, air bronchograms? And if we revise, what are the clinical features of the chest X-ray diagnostic features? If there is reticogranular pattern, chest X-ray is diagnostic. There is reticogranular pattern, ground glass opacity, low lung volumes. Why the low lung volume? Because the lung has not expanded There is air bronchograms. There is homogeneous atelectasis. Atelectasis is the part of the lung is collapsed, which causes white lung, and also the black bronchi that don't collapse. So it causes air bronchograms and the whiteout lungs, because there is the cardiac and diaphragmatic borders are not visible. So these are the chest X-ray diagnostic features. So the right answer is air bronchogram on chest X-ray. Next question is, the surfactant appears in amniotic fluid at 20 weeks, 28 weeks, choice C 32 weeks, and choice D is 8 weeks. Surfactant appears in amniotic fluid at A 20 weeks, choice B 28 weeks, choice C 32 weeks, and choice D is 8 weeks. So the right answer here is surfactant synthesis begins in fetal length, we have already discussed, at 20 weeks and appears in amniotic fluid between the 28 to 32 weeks of gestation. So the right answer here will be 28 weeks. The surfactant synthesis will begin in fetal lungs at 28 weeks and it appears in amniotic fluid between 28 to 32 weeks. So our right choice is 32 weeks. Now a case scenario, baby is born prematurely at 30 weeks of gestation by cesarean delivery, which was done for fetal distress. Immediately after the delivery, baby develops tachypnea, flaring, subcostal and intercostal retractions. On chest radiography, there were bilateral, diffuse, ground glass appearance, air bronchograms, and low lung volume. What is the best treatment plan? So if we take this question, a premature baby, 30 weeks gestation, cesarean delivery for fetal distress. So risk factors are already present for hyaline membrane disease, prematurity, cesarean delivery. Right? Next is the clinical features are present immediately after birth, and they are tachypnea, flaring, and intercostal retractions. And on chest radiography, there are bilateral diffuse ground glass appearance, air bronchograms, and low lung volume. So all these features, starting from the premature baby, the risk factors, the clinical features, and the chest X-ray, they're all favoring in favor of respiratory distress syndrome. So our diagnosis here is respiratory distress syndrome. Now, what is the best treatment plan? A, oxygen therapy. B, surfactant administration and respiratory support. C, emergency repair of tracheofistula. And D, only observation. Now, if we see here, the patient is presenting with severe respiratory distress. Now we already know in cases of severe respiratory distress, what will be the treatment? Support. We'll give the respiratory support. It is a treatment of choice here. So we won't give oxygen therapy because the patient is presenting an impending respiratory failure. No observation cannot be done because the treatment will be surfactant administration. And the respiratory support. So the surfactant administration. Next question here is, lecithin sphingomyelin ratio is done to assess the maturity of lung, fetal circulation, brain, or GI tract. LS ratio is done to assess the maturity of lung, fetal circulation, brain, or GI tract. So lecithin sphingomyelin ratio is done to assess the maturity of the lung. Something about the lecithin sphingomyelin ratio, it is a test of fetal amniotic fluid to assess for fetal lung immaturity. An LS ratio of 2.4 or more indicates fetal lung maturity and a relatively low risk of infant respiratory distress syndrome. And an LS ratio less than 1.5 is associated with a high risk of infant respiratory distress syndrome. So in this, LS ratio is done to assess the maturity of the lung. So this was about lecithin sphingomyelin ratio. It is done to assess the fetal lung maturity, and it is done in fetal amniotic fluid. And LS ratio of 2.4 or more indicates lung maturity, and an LS ratio of less than 1.5 is associated with a high risk of infant respiratory distress syndrome. The next question is, loss of pulmonary surfactant in premature infant leads to A, pulmonary edema, B, collapse of alveoli, and C, elastic recoil of lungs. Loss of pulmonary surfactant in premature infant. Obviously, there can be pulmonary edema, there can be collapse of alveoli also, there's atelectasis and elastic recoil of lungs. So the answer here is D, all. Loss of pulmonary surfactant in premature infant will cause pulmonary edema also, will lead to collapse of alveoli also, and it will further lead to elastic recoil of lungs also. Answer D is false. Which of the following disorder in the mother leads to delayed fetal lung maturity? Heart disease, diabetes, thalassemia minor, or epilepsy? Which one of the following medical disorder in the mother will lead to delayed fetal lung maturity? We have already discussed the risk factors. If we discuss, so the following, the answer here is diabetes. Diabetes is a risk factor because the increased fetal insulin or the increased fetal in the mother can lead to inactivation of the surfactant. So, which one of the following medical disorder in the mother? That can be diabetes. Diabetes is a risk factor. Next question: betamethasone injection to the mother decreases the incidence of the following in a preterm baby. First, patent ductus arteriosus. Next is necrotizing enterocolitis and intraventricular hemorrhage. And D, all of the above. Betamethasone injection. Obviously, betamethasone we have already discussed. It is a steroid, and it is done for prevention of prevention of hyaline membrane disease. So, what can be the, if we go back to the prevention, we already know it, antenatal steroid decrease respiratory distress syndrome. They help in decreasing intraventricular hemorrhage. They help in decreasing patent ductus arteriosus, necrotizing enterocolitis, and overall neonatal mortality also. So the answer here is all of the above. The betamethasone injection in mother in a preterm baby will decrease PDA, necrotizing enterocolitis, and intraventricular hemorrhage also. So answer A is D, all of the above. The next question is again for steroids. The dose of betamethasone to prevent respiratory distress syndrome is 6 mg or B12 mg every 24 hours, C6 mg every 12 hours, or 4 mg stat. So the answer here is 12 mg every 24 hours. If we go to the again to our prevention of hyaline membrane disease and the use of antenatal steroids, the dose can be 12 mg intramuscular, 2 doses 24 hours apart, and the dexamethasone is 6 mg intramuscular, 4 doses 12 hours apart. So this was about the betamethasone use. So this is the question of our day. We'll wait for almost around 5 to 10 minutes to get the answer for this. With reference to respiratory distress syndrome, all of the following statements are true except A, usually occurs in infants born before 34 weeks of gestation. B, more common in babies born to diabetic mothers. C, cyanosis can occur. Or D, it is treated by administering 100% oxygen. So I'll repeat the question again. With reference to respiratory distress syndrome, all of the following statements are true except it usually occurs in infants born before 34 weeks of gestation. Choice A. Choice B is it is more common in babies born to diabetic mothers. Choice C, cyanosis can occur. And choice D is it is treated by administering 100% oxygen. So which of these following is false? This is the question of our day, and we'll wait for around 5 minutes to get responses from the students. Any questions? Any answers? Repeat the question again. With reference to respiratory distress syndrome, all of the following statements are true, which are it usually occurs in true, except that is we have to find out which is a false statement. Usually occurs in infants born before 34 weeks of gestation, more common in babies born to diabetic mothers. C, cyanosis can occur, and D, it is treated by administering 100% oxygen. So, which of the following is false in all of these? We'll wait for a few more minutes to get response from the audience. All the choices very thoroughly, and we have already discussed all these choices in our previous discussion of respiratory distress syndrome today. So these are all choices from that discussion only. Waiting for a few more students to respond. What is the correct, what is the false statement here with reference to respiratory distress syndrome? One of the statement is false here. This is a question of a day. So give it a go, guys. Discuss. Think about it and answer. Waiting for your responses. What can be the wrong answer here? So I think we'll go ahead with the answer. We'll discuss the answer here. So with reference to respiratory distress syndrome, all of the following statements are true, except that is we have to find a wrong statement here. It usually occurs in infants born before 34 weeks of gestation. Completely right. More common in babies born to diabetic mothers. It is right. Cyanosis can occur. Yeah, there can be tachypnea, retractions, grunting, and cyanosis. D, it is treated by administering 100% oxygen. This is a false statement here because we never give 100% oxygen in babies of respiratory distress syndrome because there can be chance of a retinopathy of prematurity. The target is always to maintain SpO2 of 91 to 95%, so we never give 100% oxygen. So the wrong answer here is it is treated by administering 100% oxygen. So this was about respiratory distress syndrome or the hyaline membrane disease in a nutshell. We have covered all important points and all important topics related to respiratory distress syndrome, starting from epidemiology, the risk factors, and the clinical features about surfactant factors, the clinical treatment modality also, and the prevention of antenatal. How can we antenatally prevent respiratory distress syndrome by giving steroids to the mothers also? So this was about respiratory distress syndrome. Before leaving this discussion, I would love to thank Nextillo for giving me this opportunity to discuss a very important topic with you all. And I would ask you, and I will inform you that we have a Nextillo, this Nextillo channel on YouTube also. You can subscribe to that. We have a Nextillo app also. You can use the Helping Hands coupon, and which can be there is a 89 rupees for next 3 months, which can help you a lot. And I will thank again Dr. Sunil for giving me this opportunity to discuss pediatric lectures with you all. So thank you all, everyone, for listening to this my pediatric lecture series, and all the best to you. Thank you very much.